for joining us for this virtual community lecture focusing on cardiac care and heart health. My name is Brian Kawasaki. I'm the Communications Director here at Providence St. John's Health Center. As you may know, February is American Heart Month, and we're so glad you can join us as we wrap up this month of awareness with this informative webinar where we hope you'll learn a few things today that will possibly help keep you heart healthy. Today, we are joined by Dr. Rigved Tadwalkar, a consultant cardiologist with the Pacific Heart Institute at Providence St. John's, Dr. Stephen Tang, a cardiac electrophysiologist with Pacific Heart Institute, and Dr. Peter Pelikan, medical director of our cath lab here at Providence St. John's. Before we get started, I want to just lay some ground rules out that this is an hour-long discussion, and we'll have plenty of time for questions at the end of our physicians' presentations. Please use the Q&A box to type in any questions you might have throughout the presentation, and we'll do our best to get to each question at the end. We will not be opening up for attendees to speak on this webinar. With that said, it's my pleasure to introduce our first expert on today's panel. Dr. Tadwalkar is a consultant cardiologist with the Pacific Heart Institute. He is a fellow of the American College of Cardiology and the American College of Physicians, and is board certified in cardiovascular disease, echocardiography, cardiovascular computed tomography, nuclear cardiology, and internal medicine. He provides a full range of non-invasive and invasive diagnostics, as well as conventional and novel therapies. He additionally offers concierge services through an enhanced access program delivering exceptionalized personalized care. With a passion for digital health, Dr. Tadwalkar co-founded the Committee on Technology with the California chapter of the American College of Cardiology, the first state-level chapter of a medical specialty organization with a committee of this type. Dr. Tadwalkar's additional clinical interests encompass the full spectrum of cardiovascular disease and include multimodality imaging, interventional echocardiography, diagnostic catheterization, and prevention. Dr. Tadwalkar is an emerging voice in the field, cited in a variety of leading healthcare media on the latest topics. He has been elected to the Super Doctors Rising Stars list annually since 2020, an honor bestowed to approximately only 2.5% of physicians in a particular state or region. And we are so glad to have him join us today. Dr. Tadwalkar, thank you so much for being here.
Thank you so much, Brian and Christina, for organizing this webinar. It's very much appreciated. Are you able to see my screen? Let me just make sure that we're all set up here.
Yes, we are.
Perfect. Okay, give me one moment here. Okay, wonderful. Well, thank you again. And thank you everybody for attending as well. I'm going to talk to you a little bit about cardiac care with the Pacific Heart Institute and Providence St. John's Health Center. But for those of you who are on the call with us today, you're probably already aware that cardiology deals with matters of the heart. In fact, we're the medical subspecialty that deals with these disorders. However, you may hear the term cardiovascular disease. And what that means is that we're also focused on blood vessels. So that includes blood vessels that lead to the heart itself, leads to the neck, leads to the arteries of the lower legs, the kidneys, etc. So this is very much a systemic specialty. But some things that you should know about heart disease, and these are data pulled from the Centers for Disease Control and Prevention. Heart disease, as you may already be aware, is the leading cause of death for men, women, and people of most racial and ethnic groups. Accounts for 1 in every 4 deaths. That's about 660,000 people in the United States per year. 1 person dies every 36 seconds in the United States from cardiovascular disease. And while we think of this as a disease of age or the elderly, about 2 in 10 deaths from coronary artery disease happen in adults less than 65 years of age. About 800,000 people in the US have a heart attack annually. It's almost 1 million people. And about 1 in 5 heart attacks is silent. It means that you may not even be aware. You may have just had a day where you felt a little bit of indigestion or fatigue, but in reality, a heart attack may have occurred. So you may ask, well, then what are some risk factors and causes of heart disease? So I like to put these in 3 different buckets. So you have your medical issues, things that many people do in fact have: large body habitus, elevated body mass index, high cholesterol, high blood pressure, diabetes, or a collection of these disorders. We call that metabolic syndrome. Also, sleep apnea, which many people are not aware can actually lead to cardiovascular disease or be associated with it. And then rheumatologic disease, things like lupus, rheumatoid arthritis. So as you can see, a number of different medical issues can be implicated. From a behavioral standpoint, unfortunately, this is stuff that many of us have been under more recently, which is emotional stress and anxiety in the context of the pandemic. And certainly that is a risk factor and cause of heart disease. Lack of activity, poor diet, tobacco, illicit substances, and even certain herbals and supplements. So, it's important that you're able to run these by your physician to see if in fact they're safe, because not a lot of supplements or herbal preparations that are out there are regulated. There's also non-modifiable things. You might be born with heart disease, congenital disease, as we like to say. Age plays a role, ethnicity because of socioeconomic factors, genetics, family history. If you have a family history of heart attack or coronary disease, you might be more likely to have this as well. So what are the different types of heart disease? So we have coronary heart disease, which we often will call coronary artery disease, rhythm issues of the heart failure, which is when the pumping function of the heart is not appropriate, and even heart valve disease, where the valves, and there's 4 heart valves, when one of these or a number of these has a disorder. And of course, there are many more, but these are just the standard initial buckets that we often put heart disease in. So the good news is I just want to take a brief moment to talk a little bit about preventative care. The good news is that there are tips and tricks, so to say, things that you can do today to make your risk of heart disease much less. And I want to talk about the first 2 on this list of 7. This list of 7 is widely available from the American Heart Association. And you can see what these things are. It includes getting active, eating better, losing weight, stopping smoking, managing blood pressure, controlling cholesterol, and reducing blood sugar. So I'm going to talk to you briefly about the first 2 to start. So what does getting active mean, right? So we always hear this, but there's no formalized definition. And what getting active means, it means greater than 150 minutes of moderate activity or greater than 75 minutes of vigorous activity per week. So you may ask, well, how do you define moderate or vigorous activity? Well, moderate activity we define in METs, and the range that we use is 3 to 6 METs. And you may ask what a MET is. But a MET is a metabolic equivalent, where 1 MET is equal to the amount of energy that is expended just sitting and resting. 3 to 6 METs, you may ask, well, what kinds of activities are these? And this includes brisk walking and carrying groceries, things of that nature. Vigorous activities, anything greater than 6 METs. This includes playing basketball or soccer or vigorous swimming. These are all things that would account for this sort of activity. And if you're looking for a list of activities or examples of what consists of mild, moderate, or significant or vigorous activity, then this is all available to you, even if you look online. It's important if you're starting on an exercise regimen to set goals. And those goals can be small at first, and then you sort of want to build those up and keep it going so that ultimately these become a habit. I do want to talk about something called adding it up. And what adding it up means is that besides just allocating a certain part of your day for physical activity, you should in fact try to make attempts to add more physical activity through your day-to-day routine. So that includes maybe parking a little bit farther when you go to the grocery store or you go to an appointment, taking the stairs instead of an elevator. These sorts of things day to day and week to week and over the course of some time and months make a big difference in terms of the amount of activity you're performing. And I'll say, when in doubt, if you're not sure where to start, just take a walk. So if you're not sure, you're busy, you're stressed, you have a lot of other activities on your agenda, take 10 minutes out to just walk around the block or walk around your neighborhood. And not only will that make you feel better, but in fact, this will be the first foundation in treatment of cardiovascular disease. And of course, eating better is a big part of this as well. And the most important thing is creating a healthy dietary pattern. So you want to enjoy things like whole grains, vegetables, fruits, nuts. It's just a matter of substituting your diet with some of these, or next time you go out to get food or get groceries, to get things of this nature instead of the usual things you might potentially buy. Plant-based protein. So not all protein has to come from meat. If you are going to have protein from meat, fish is a great source. And then you want to limit things that unfortunately are widely available and very easy to get. So that includes sweetened drinks, processed meats, refined carbohydrates, full fat dairy, very easy substitution to go into a low fat dairy product, very widely available. And then tropical oils, things you want to avoid are palm oil, coconut oil, things like that. Replace those with olive oil, flaxseed oil, things like that. The good news is because of legislation, we've done a very good job in terms of being able to have nutrition labels on things. So you want to know how to read a nutrition label, and specifically, one thing to look at is the sodium content. So how much salt does something have? Sometimes things are marketed as health foods, but they have a lot of salt within them. And so know your hidden sources of sodium. That includes soups, bread rolls, sandwiches, pizzas. These are things you want to try to minimize or avoid. One of the good things, if anything, that came out of the pandemic is many people are comfortable cooking at home. And one of the advantages of cooking at home is now you don't have the usual additives that you would get from the outside, and you know exactly what's going on with your food. And ultimately, the whole point of this is that beyond just picking good sources of food and nutrition, you want to watch your calories, right? So when you do all this, the simple equation for weight loss is calories in versus calories out. And so even though that sounds simplistic, it works every time. It's just a matter of finding a way to track it and do it appropriately. And being able to watch your calories by just cutting your portion sizes, even if it means cutting it by a quarter or a half every time you sit down to eat, will make a substantial difference in impacting your cardiovascular health. So we've talked about 2 of these 7. And of course, losing weight, we sort of touched on. Stopping smoking is somewhat obvious and is a known risk factor for heart disease. But what about the others, like managing blood pressure, controlling your cholesterol, reducing your blood sugar? These are a lot more challenging, and that's where you might need some help in getting this done. And that's really where we come in. As the Pacific Heart Institute and St. John's Health Center, we are your destination for cardiac care. So I just want to talk a little bit about our practice, but the Pacific Heart Institute, we are a long-standing premier cardiology practice. We've been serving greater Los Angeles and beyond. More recently, we get referrals through California. Many people visit us for their cardiac care as well. And beyond our Santa Monica office, which has been long-standing, we do also have offices in Playa Vista and Beverly Hills. And pictured there on the right is our office in Playa Vista. We have board-certified cardiologists. In fact, many of us, if not all of us, are boarded in more than one specialty within cardiology, and we have extensive subspecialty training and experience. And we take pride in bringing the latest innovation and research along with a highly collaborative approach to treating patients. So here are some categories of care, and my colleagues, Dr. Tang and Dr. Pelikan, are going to be speaking with you about some of these categories as well. I'm just going to briefly touch on a little bit of this. But if you come to our practice to be evaluated for common issues such as hypertension or hyperlipidemia, we're going to take the next step in terms of evaluating this further, making sure you're on a good treatment regimen, and making sure we're preventing the onset as best as we can of cardiovascular disease. And certainly if you have these as established diagnoses, we'll work in conjunction with your primary care doctor to really hone in on your treatment plan. You may have some occult or hidden coronary disease or vascular disease. Those are things we'll take care of. Post-stroke care. If you have valve issues, you may have heard of a diagnosis called aortic stenosis, which is a common valve issue. That's something we can take care of as well. Arrhythmias, heart failure, etc. This is a busy slide, but this just goes to show you that we do the whole spectrum of diagnostics and imaging. Everything from a routine EKG, advanced laboratory and genetic testing, to ultrasonography, all kinds of stress testing. We have all modalities available in our practice to be sure we're diagnosing your heart condition correctly. We have a whole range of treatment modalities. I've sort of arranged these with some of the interventional therapies on the left and the electrophysiology therapies on the right. And Drs. Tang and Dr. Pelikan will speak with you about these in more depth, and how we select our patients and how we get people to these procedures, and what that looks like in terms of your management plan. Briefly, before I finish, I just want to talk about a couple of special programs that we offer. We do have an enhanced access program, which is unique to our practice. as compared to many practices around the region. And basically, this is a fee-based concierge medicine program for those who want to participate that allows for access to special services and amenities that insurance normally doesn't cover. So this allows for highly personalized attention, more one-on-one time, which is very difficult to find with doctors these days. It allows for a more meaningful relationship with your caregivers and your care team, easy access and flexible scheduling. There are 3 different tiers to the Enhanced Access program, with the popular options being Select and Premier. But just brief highlights on the Select program for those who are interested. This allows for priority office appointments and scheduling. So if this is something that you have a hard time getting into your office, you may have a cardiologist or other physician that you have a difficult time seeing, this program allows for that access a little earlier on. In the Premier program, this allows for direct email communication with your doctor and other perks like in-office lab draws. And on the concierge side, for those who are interested, maybe you're particularly sick, maybe you're worried about a loved one who really needs that attention in a focused manner, we allow for direct 24-hour access to the doctor via text, cell phone, email. There may be availability of appointments off the usual business hours, evening, weekend, holidays, and you get personal phone calls to discuss results in your care plan as it unfolds. Lastly, I just want to talk about the Women's Heart Center. We are tied in very closely with the Have a Heart, Save a Heart charity, which is our nonprofit charity organization. And our mission is to raise awareness of women's heart disease by looking at a whole spectrum of different ways. So that includes symposia that we do, including an annual symposium we hold each February, where we talk about the latest in women's heart health and cardiology in general. And it's an opportunity for our community to engage with us as we talk about the latest in what we do with our practice. So with that said, I just want to turn the attention away from me and onto my colleagues, Dr. Pelikan, Dr. Tang. Thank you very much for taking the time to listen. And if you have any questions or concerns, we're always available, and we'll be sure to provide our contact information so that you can get in touch with our practice should you need us. Thank you.
Thank you so much, Dr. Tadwalkar. And some of those numbers you showed early on, I think were glaring, right? I believe you said 659,000 deaths per year, and 1 in 5 heart attacks are silent, which is a really scary thought. Staggering, right? I mean, that's scary. You would assume that you would know you're having a heart attack, right, if you're having one. And I know you outlined a lot of these risk factors or causes, as well as preventative care tips, but how important is it for people to discuss these things with their physicians early before problems start arising? Or is it important for people to kind of get a gauge on their heart health early? And what are some of the benefits of doing so?
Yes, absolutely. In fact, we live in an amazing era of preventative care today. So what's interesting about cardiology is that before, there was a time when you would have to be very sick to see the cardiologist. Like, things would really be, quote unquote, falling apart, where other doctors have not been able to really get to the root of your issues. You're really in dire straits. And certainly we do still see those patients, but a lot of patients now come to us for preventative care because they might have a heart history or they're developing these risk factors. And it's of the utmost importance because prevention is the best medicine. So identifying, what your issues are early on is a big key in order to manage somebody successfully and making sure that you're getting the right care so that we can prevent you from ever having these issues, or at least make it as less likely as possible that these affect you early in life.
Awesome. Thank you so much. And I do want to just quickly remind everybody that we are going to have Q&A, or a session for Q&A toward the end. So if anybody has questions, please feel free to drop in the chat box and we'll discuss those toward the end of the lecture. And I do want to remind everybody that this is being recorded. So for whatever reason, if you want to look back on this video, we will have that. We will post it for everybody afterwards. So right now we'll turn our attention to Dr. Pelikan. Dr. Pelikan is a native of New York City who graduated from the Bronx High School of Science. He majored in biology at Yale University and graduated from Harvard Medical School in 1979. After an internal medicine residency at Harbor UCLA Medical Center, he completed a fellowship in cardiology at Johns Hopkins in 1985. After realizing how much he missed Southern California, and who can blame him, Dr. Pelikan couldn't wait to return to Harbor UCLA Medical Center as an assistant professor of medicine and co-director of the Cardiac Catheterization Laboratory. In 1989, he left academic medicine to join Pacific Heart Institute, where he has been an interventional and consulting cardiologist ever since. Dr. Pelikan is the medical director of our cath lab at St. John's Hospital. He has served as medical staff president and is active in hospital leadership. His medical interests include coronary and structural heart intervention, actively performing coronary stenting, TAVR, MitraClip, and Watchman implantation. He's also active in peripheral angiography and intervention stenting, as well as consultative cardiology. Dr. Pelikan, that's quite an illustrious resume, if I don't say myself, and that's probably even an understatement. Thank you for joining us.
I don't even recognize myself. Well, I want to just sort of follow up on a couple of the things that that you've said and that Rigved has said. First of all, in the older days, cardiologists essentially focused on the heart itself. We now look at ourselves as cardiovascular specialists. So we are interested in diagnosis and intervention and maintaining the health of blood vessels throughout the body, not just in the heart. So as you said, the interventional docs in our group and at the hospital, Dr. Brukim, my partner in interventional cardiology here, and I, actually Dr. Brukim right now is doing an angiogram and possibly an angioplasty on someone's leg artery because they're having pain in their leg while walking, probably from a blockage in the artery as it passes from the thigh and goes down to the calf. So we are interested in all blood vessels. We actually even used to do the carotid artery stenting. These are the arteries in your neck going up to the brain to prevent stroke. We now have a very active interventional neurology or neurointerventional program in the hospital who live and breathe that type of intervention. So Dr. Brukim and I are no longer working above the collarbone, let's say. Dr. Tadwalkar mentioned heart attack. We do participate, hopefully you don't know because you haven't used it, but Los Angeles County has a heart attack receiving program. It's called a STEMI receiving program. STEMI is an acronym for having a big heart attack. So if you were to call up 911 and say, I'm having chest pain, you would, paramedics would be at your house, hopefully in 5 minutes or so. They would do an electrocardiogram on you, electronically transmit that to the hospital to alert us that you're on the way to the hospital, and on arrival have a brief exam and hopefully as soon as possible be brought up to the cardiac catheterization lab where we would be able to inject X-ray dye, identify a blocked artery, and either suction the blood clot out of the artery or balloon the blood clot such that we reestablish flow. Blockage is causing the heart attack, so we would reestablish it and stop the heart attack in its tracks. The goal in LA County is we look at something called door to balloon time. So when you hit the door, we would like to have a balloon in your artery and have the artery opened up within 90 minutes. And if we can do that within 60 minutes, that's even better. The longer the artery is blocked, the more damage there is to the heart. I just want to touch on one other thing, and that is I did specifically say call 911. We do have patients who drive themselves to the emergency room, having an elephant sitting on their chest, which would be one of the common symptoms of having a heart attack, or have a family member or a friend drive over to their house after 20 minutes and then pick them up and drive them to the hospital. So there are many reasons that's not a good plan. First of all, it's not as quick as being in an ambulance with a siren. And second of all, people who have heart attacks have complications of the heart attack, abnormal heart rhythms, as you saw in Dr. Tadwalkar's slides. Sometimes abnormal heart rhythms can make you pass out or worse. Sometimes you could be in shock. Your wife or your husband or your friend are not trained to deal with that while they're driving you in a car. So we strongly recommend, if you think you're having a heart attack, 911, let the paramedics assess you and get you to the hospital as quickly as possible. While I'm on the topic, what are the symptoms of a heart attack? The most common symptom is chest discomfort. I'm specifically using the word discomfort instead of pain, because the discomfort in your chest is more typically pressure or heaviness, and it's unusual to be a knife-like sharp pain. Shortness of breath, discomfort in the throat, the jaw, the arms, profound sweating, all of those could be considered symptoms of a heart attack. So if you are concerned about it, it's much better to get attention by calling 911 than sitting at home and thinking, you know, you had too many nachos and beers and it's probably heartburn. Because if you're correct and it's heartburn, then hopefully you'll figure that out in the emergency room. And if you're incorrect in assuming that it's heartburn, it may be the worst mistake of your life to make that assumption. You want me to I have a couple other things to say, Brian, or do you want me to stop?
Yeah, no. If you have a couple other things, I do have one question for you, and maybe you can answer that right now. You know, as the medical director of our cath lab, you talked about, you know, some of the leading edge services and treatments we provide. God forbid anybody actually need these services, but can you shine some light on that? Because I know St. John's has been a pioneer in this field for many, many years. So what are some of the innovative things we do here should somebody need, you know, cardiac care?
Perfect. That's where I was heading anyway. So great. So basically in our cardiac cath lab, we have a number of different physicians in different specialties, but essentially short of doing a heart transplant, which you wouldn't do in the cath lab, anything that's available in modern interventional cardiology. Interventional cardiology is the portion of a cath lab procedure where you're actually doing something therapeutic, putting in a stent, for example. Structural heart disease, meaning putting in a valve or putting in a Watchman device. Electrophysiology, you're going to hear from Dr. Tang, so I won't say much about that. But we have it all. So 2.5 years ago, we opened a TAVR program. TAVR means putting a new aortic valve in place through a catheter, through a tube that's inserted into the artery, usually in your groin, so that instead of having open heart surgery, 6-hour operation, having your heart stopped, having the blood taken out of your body and pumped through a machine to help you survive while your heart is stopped, recuperating in the hospital for a week, and then going to cardiac rehab for 6 to 12 weeks to feel better. This is basically a percutaneous procedure done by puncturing the artery in the groin. Most of our patients are going home the next morning. There are programs around the country doing outpatient, meaning go home the same day. I have not brought myself to having the nerve to do that, but typically in overnight, home the next day. You could take a 5-mile walk the next day if you wanted. We've done in the past, whatever it is, 2.25 years, about 120 TAVRs, and patients are just doing fine, doing great, and feel a lot better. We are able to put a clip on the mitral valve if there's a significant back leak in the mitral valve. If you've previously had surgery on the mitral valve, we can actually put a new valve inside the old valve. We can do that both in the aortic and mitral position. So we're kind of an all-purpose lab. If you're having an aortic dissection, this is a life-threatening event, severe chest pain, usually with back pain. where the lining of your aorta, the main blood vessel bringing blood from your heart to your whole body, can tear. It can actually rupture so that you're bleeding out inside your chest. We have physicians who can actually put a Dacron coated sleeve into your aorta, again, through a puncture site in the groin, and basically save your life. The cath lab, unfortunately for me, is open 24/7, 365. So if you're having an emergency at 2 a.m, hopefully we'll be up there together, or with, even better, with one of my partners who might be on call instead of me. But, you know, hopefully up in the cath lab 20 minutes later, artery opened within 30 minutes of that, and home a day or two later, as opposed to allowing a heart attack, for example, or in the case of an aortic dissection, you know, allowing the person to survive and do well. So
Yeah,
I think, I'm sorry,
go ahead. Sorry.
I was going to say, I'll stop there unless you can tell me I've missed something here.
No, I think that's great. I mean, recovery times are just remarkable these days. And, you know, but to Dr. Tadwalkar's point, you know, that's why preventative care is so important, being able to take, you know, the right precautions. And
if I can mention, you know, since you told everybody that shortly after the Lincoln assassination, I graduated from medical school. But when I was in medical school in the late 1970s, every hospital had a solarium. You know the word sol, that's the scientific name for our sun. And if you had a heart attack, since there was no therapy for a heart attack, you would be in the hospital for 30 days recuperating, because they didn't want you to walk, they didn't want you to get perturbed, and they would put you in a chair and wheel you into this solarium, which was a room with a glass window and roof, so that you could actually get a little sunlight while you were in the hospital. So, and then, you know, if you survive those 30 days, you would be debilitated the rest of your life. And compare that to, you know, huge heart attack Monday morning, home Tuesday afternoon or Wednesday morning, back to work the next Monday, and exercising a month later. It's a fabulous world. I'm happy I went into cardiology, because, you know, the changes that have occurred to allow us to deliver better care quicker and get people back on their feet, which is really what it's all about. It's been incredible.
absolutely. And I think it's equally as exciting to see where technology and where we'll advance to in the next 10, 15, 20 years, you know?
Right.
So, well, thank you so much, Dr. Pelikan. We're going to actually move on to Dr. Tang at this moment, and he's our last, but not least, expert we have on our panel. Dr. Tang is a cardiac electrophysiologist who joined Pacific Heart in 2020. He specializes in catheter ablation for cardiac arrhythmias and implantation of pacemakers and defibrillators. He has a particular interest in novel and innovative therapies in the management of cardiac arrhythmias, including a lifelong passion for designing cardiac devices. He earned a bachelor's degree in biomedical engineering from Duke, then worked for several years in the cardiac device division of a large medical device company. He later earned his medical degree from the University of Cincinnati College of Medicine before moving to Los Angeles for the remainder of his medical training. He completed a residency in internal medicine at Cedars-Sinai, and additionally, he completed fellowships in general cardiology and clinical cardiac electrophysiology at Kaiser Permanente, Los Angeles Medical Center. He is board certified in cardiovascular disease, internal medicine, and echocardiography. He's an active member of the American College of Cardiology and Heart Rhythm Society. Dr. Tang, thank you so much for joining us. It's an honor to have you.
Thanks, Brian, for that presentation. Can you hear me okay?
Yes.
Okay, all right. Well, thank you for this opportunity to talk about what I do for a living. I'm thankful that I actually had to rush out of a procedure, not rush, but I finished a procedure not too long ago about one of these ablations that we'll talk about shortly. But let me see if I can pull this up. So I put together some slides here. Can you see this presentation here?
Yes.
Okay. So, So yeah, we like to distinguish ourselves a little bit from the other cardiologists. So we like to think of us as a sort of cardiac electrophysiology is like being an electrician of the heart. And so I'm one of 3 electrophysiologists in our group, actually 4, someone else recently joined us, but 3 of us are based at St. John's. So that's myself, Dr. Banerjee, and Dr. Doshi. And we deal with primarily most heart arrhythmias. And then in addition to that, we have a primary focus on atrial fibrillation, which is a very common disease we'll talk a little bit more about. So just some things that usually end up with people coming to see us. So some common symptoms people are complaining about. The most common one is palpitation. So this is just a general term for a lot of different symptoms sort of encompassed together, but that can include fluttering or racing of the heart or an irregular heartbeat. Some people get dizzy along with these sensations. In certain cases, people can be fatigued. Other cases, people are passing out, or something we call syncope, and having fainting spells. Sometimes it manifests as chest pain, and that's not necessarily a heart attack, but some sort of arrhythmia, and then shortness of breath also could be another manifestation. So when you come to see us for consultation, basically, there are a lot of things we can do, but we always start with a very thorough and dedicated sort of targeted history and physical. So we're trying to identify, are there any risk factors for things like, if you have family history of people with lots of arrhythmias, or if there was, we'll ask you about your sort of social history, and meaning, are you drinking a lot of caffeine or alcohol or things that might sort of cause issues with heart arrhythmias. And then encompassed with that would be sort of a basic sort of lab panel where we look at your electrolytes, your thyroid function, your kidney and liver function to see if anything these are contributing. We'll get a baseline 12-lead ECG, which kind of gives us a picture of what your baseline electrical system looks like. And then if you are complaining of symptoms, you'll very likely get something called a Holter monitor, meaning there is basically a patch monitor, which I'll show you here. Let's see if we can show a picture here. Basically, we have 2 different types of patch monitors. Now, it used to be with the Holter monitor, you had to have multiple different electrodes on your chest, but now these have all been replaced with essentially stickers that have a little recording device on it. And here are the 2 different common ones that we use. Is something 2 different companies are shown here, but they can be on your chest and stay there up to 2 weeks if need be. Kind of like what Dr. Tadwalkar was alluding to, often an echocardiogram, a stress test would be an important part of sort of identifying, is there something in terms of a blockage in the heart, or is there something structural in your heart that's causing these arrhythmias? And then there is a strong association with a lot of the arrhythmias we do in something called sleep apnea. So very commonly we'll order a sleep study for you if you have a history of snoring, or if your wife or husband next to you says you stop breathing at night. So, and then there are certain things sort of like genetic testing. There's certain genetic predisposition for arrhythmias that we may screen you for. So, and often, depending on what we find, there's a whole host of medicines that we could use for this, or even blood thinners that come along with some of the arrhythmias that we may deal with, or we may just sort of observe what's going on. But I like to break down the arrhythmias into a couple different categories. So, first foremost would be sort of slow heart rhythms, or what we call bradycardia. So that's generally a heart rate less than 60 beats per minute. This, of course, can vary. There are some athletes whose heart rates run in the high 20s or low 30s, and it really depends on if you have symptoms along with this. So, but there are some conditions here called sick sinus syndrome, meaning your own internal pacemaker, which is called the sinus node, doesn't properly function, or something called heart block, meaning the signal from the top doesn't reach the bottom part of the heart. And both of those can manifest as slow heart rhythms. Another category that we very commonly deal with are the fast heart rhythm. So anything greater than 100 beats per minute is sort of considered a fast heart rhythm. And these are common types of fast heart rhythms that we deal with in our field. So atrial fibrillation, atrial flutter, something called supraventricular tachycardia, which is a fancy word for just arrhythmias coming from the top part of the heart. And then there are arrhythmias from the bottom part of the heart called ventricular tachycardia or ventricular fibrillation. And then another category we commonly deal with is there are very frequently people have something called premature heartbeats, and these can either come from the atrium, so premature atrial contractions, or premature ventricular contractions, and these often can cause symptoms in a lot of people. So based on what we find, there are a couple of different treatment options for devices that we might recommend. Let's say your heart rate is very slow. There's something called a pacemaker. A pacemaker basically is a device, and I'll show you a little video in short that it is essentially a simple timer. It looks and monitors your heart rate, and if your heart rate wants to drop below a certain heart rate, it will kick in and make your heart beat during that time. There's something called implantable cardiac defibrillator. So as you commonly may see on television shows, when someone's heart stops at the hospital, they often put a defibrillator on the chest and try to shock the heart back to life. If this happens, in certain cases, if it's not for a reversible reason, if someone is resuscitated, often someone will go home with a implantable defibrillator to help protect them from this happening again in the future. So these are done very similarly to pacemakers with devices underneath the skin. And then there's something called an implantable loop recorder, meaning there are some devices that that can actually act as a long-term Holter monitor that we showed earlier, but can record your heart rhythm for up to 3 to 5 years. And it can sync with your phone Bluetooth. So let's say you have rare times where you're passing out and we can never catch it in the hospital or on one of the traditional loop monitors, we can put this underneath the skin, basically a simple injection device that will help us monitor your heart rhythm up to those 3 to 5 years. So, and then these are sort of some pictures of common sizes of these devices. There's several different companies we use, but basically this is what a pacemaker looks like. If you need an implantable defibrillator, this is what that looks like. And then I'm going to show you a video of a device we've been putting in for the last few years called a leadless pacemaker. So it's almost the size of a vitamin capsule that we've been putting in the bottom part of the heart. I'm just going to exit for a second because I couldn't figure out how to mute this, but basically I'm going to show you a video here of, so for a long time, pacemakers, there was only one way to put them in. It was using the vein in the arm. And what we'll show here is a vein in the arm, and basically you would get a pacemaker device that you would connect back to this wire that you would put into the heart, and this would be placed underneath the skin. So for a long time, that was their only option for putting in pacemakers. If we had no access to your vein, basically what we would have to do is put it on the surface of the heart, and the surgeon would help put those leads on top. But now companies are in development, and this is the first of probably a few companies that are going to create these sort of leadless pacemakers. So what that means is instead of having a wire in the heart, you actually have this device which acts almost like acts as its own internal pacemaker with the whole generator and the lead itself underneath the skin, and it's actually delivered through the vein in the leg. So basically, we give you if you come for this procedure, we give you a little bit of Valium and Benadryl, and we access the vein in your leg, and we basically numb up that groin, and we go and we follow that vein all the way up in the heart, and basically use this special sheath to deliver this device underneath the skin and into the bottom part of the heart. And then we can check this device and make sure that it's appropriately working prior to releasing it. But basically, you end up with a device at the end of it that is all encompassed in one, and this thing can last for 8 to 10 years and not need any sort of battery change. So it's become a very sort of great option for a lot of patients who just need occasional pacing or have this other rhythm called atrial fibrillation, because it allows you not to have an incision in the chest and the sort of infection risk that comes along with it. So it's something that really has changed our field more recently. So the next thing I just wanted to talk about is, and I know I'm running out of time, there's some very common arrhythmia that we deal with called atrial fibrillation, and it has a strong association. So if you look at the population of the US, probably above the age of 70, 10% of people have this arrhythmia, and then above the age of 80, about a quarter of the population in the US have this arrhythmia. So one of the things, the biggest thing we honestly worry about this arrhythmia is its risk of stroke that comes along with it. And there's an area of the heart called the left atrial appendage, which basically is this appendix of the heart, which during that arrhythmia, clot can form in that heart. And for a long time, the only therapy for this was giving you blood thinners. So common ones would be Coumadin or warfarin or Eliquis. And these are medicines that unfortunately thin your blood, so there can be side effects from it. But what we've been doing probably for the last 5-6 years at Pacific Heart, and Dr. Pelikan does this procedure as well, is there's something called a Watchman device. And the idea is that you can basically plug that area of the heart. So here's the device shown here, but basically what we would be doing is passing a catheter again through that same vein that we used before, and we pass that into the heart, and we puncture a small hole through the middle part of the heart to access that area of the heart. And the idea would be that one, we're showing a couple of different types of left atrial appendages that are here, but this device is sort of a one size fit all. There's numerous sizes, but almost every appendage we have a size for. And the idea would be here, we show that a device essentially can be deployed into this area so that even if there's clot in the bottom part of this appendage, it can't get out and can't get in. And you have to be on blood thinners for a short period of time, but after that period of time, what happens is your body grows over this device. So after about 3 months, you're just on a baby aspirin. And it has been shown to be just as good as these blood thinners for preventing stroke long-term. And then, so finally, the last thing, and I'll be quick about this, something near and dear to my heart is we do a very common procedure, and one I just finished is something called intracardiac ablation. So these are very common arrhythmias that we do for this, but these can include atrial fibrillation, atrial flutter, something for SVT or ventricular tachycardia. We actually can go looking in the heart, and I can show you here. So we basically, very similar to a lot of those other procedures, in our field, we commonly use that vein in the leg to basically pass catheters into the heart. And what we do is we have very sophisticated sort of mapping equipment where we can create sort of three-dimensional pictures of your heart and voltages in your heart, and actually locate where there's short circuits in your heart that are causing your arrhythmia. And then after we locate those short circuits, we basically use an ablation catheter to cauterize that tissue and get you back into a normal heart rhythm. And here at St. John's at Pacific Heart, we sort of pride ourselves. Most of us have eliminated fluoroscopy, which is X-ray, meaning the equipment for a long time, we had to use X-ray to locate where the catheters were and to see how hard we were pushing. All these things, there have been pressure sensors sort of embedded into these devices. There's sort of these navigation chips in the device and these catheters themselves. So we essentially most of the time don't use any X-ray for our procedures. And then for most of these procedures, you can go home the same day, several hours after the procedure itself. So again, there's 3 of us, well, now 4 of us. Dr. Arshian Nouri will be, is the 4th one who joined us, our group. But yeah, we're happy to see you for any of your concerns in the future. And certainly, hopefully that was a helpful sort of depiction of things that you might encounter when you visit us, or to help treat your arrhythmia in the future.
Yeah, thank you so much, Dr. Tang. I mean, I think that goes back to what Dr. Pelikan was saying, right? About the benefits of having the ability to deploy non-invasive procedures to treat conditions that are extremely pervasive, like AFib, which you said could lead to a higher risk of suffering from strokes, right?
Exactly. And I think that's one of our biggest sort of concerns with this heart rhythm, aside from the rhythm itself. But yeah, it really has become a big focus of sort of stroke prevention going forward.
So I have a question, maybe before we open it up to the larger group for Q&A, but I don't know how accurate this is, but I've heard an analogy that you can think about the heart almost like the plumbing and electrical wiring of a house. Is that true? And I guess, electrophysiology would of course fall under the latter, but is that a good way for people to think about it, their heart health?
Yeah, I like that analogy. I mean, I tell people when they come to see me sometimes that, like, Dr. Tadwalkar would be your sort of general contractor, and he would make sure that, the walls and the doors are working in your heart. And, Dr. Pelikan would make sure the plumbing is good in your heart, and make sure there's no blockages, and that the water is flowing good. And then, I would make sure sort of the short circuits in your house, all the electricity, getting rid of all those errant wires and problems in the wall, because so there are numerous components to the heart that I think are important. And sometimes you need to see all 3 of us or just one of us, but I think we all sort of specialize in each one of these, and I think it's hard to encompass that all. And cardiology has changed a lot over the years, and I think really you need a sort of multidisciplinary approach to treating a lot of these diseases. So.
Excellent. All right, I think what we'll do now with the remaining time is we're going to open this up. I know there's already some questions in the chat. And our first question is from Bertie, who says, are there any supplements in particular that are known to be an issue? And I think this question is for Dr. Tadwalkar. This was posted when you were discussing some of the preventative treatments and maybe things to look out for.
Yeah, sure. Thank you. That's a great question. And in fact, it's a question we get a lot because these days supplements are just so popular. And quite honestly, the supplement market is big. It's difficult to sort through and to know sort of what's good for you and what's not. And I'll tell you, I'll sort of give you a few answers to this question. So one, I want to talk about things that oftentimes we think could potentially be good for the heart, but you have to be careful with. So one is a supplement called red yeast rice, which is in fact where the initial statin, which you may have heard of, medicines to treat cholesterol, was isolated from. And in fact, red yeast rice has the first statin, which was isolated, lovastatin, contained within it. So it is in fact a naturally occurring compound. The problem is that with red yeast rice, when you pick it up, it's difficult to know how much of the active ingredient, that active lovastatin, you're actually getting when you pick it up. So it may be small amount or a very large amount, or in some cases so minimal that it really just doesn't have an effect at all. So in a sense, you may think that you're getting an appropriate effect with cholesterol lowering, but in reality, you're actually not getting much at all, if anything. And so in a sense, this is harmful because, you think you're getting a benefit, but you're not actually getting the benefit that, you were intending to. Same thing goes for fish oil. Fish oil is one of those substances that, as years go on, the pendulum swings back and forth. Is this something that's good for us? Is it something that's not good for us? There's been so much about this in terms of how it's been studied. What we've learned is this: there's really just one specific type of fish oil thus far that is a special EPA fish oil that for certain types of patients, patients with lots of cardiovascular risk factors or who have had a prior history of heart attack may in fact be helpful. It's branded under the name Vasipa. Doesn't mean everyone should take it. It's just, a prescription only fish oil. But outside of that, we have not seen any clear benefit with fish oil, and rather it may have a little bit of a blood thinning effect when combined with other quote unquote blood thinning medications might in fact be harmful. To share just a quick anecdote, I've had a patient who, had been on other blood thinners or antiplatelet agents and has also been on fish oil, who ended up having a bleed into the brain. So, and it wasn't, known that, he was taking such high doses of fish oil. So you have to be careful with many of these. And just briefly, just to kind of move forward, be careful, I will say, just because it's an important one, with just plain calcium supplements. There is some evidence that when you take, now vitamin D is different, but calcium in of itself, when supplemented, not necessarily through diet, but when you're taking it exogenously as a supplemental capsule or tablet, there is some recent data that when sort of looking at everything in total, this may potentially have a harmful effect for the heart. So the bottom line is that you want to ask your doctors about this. And specifically, if you're worried about heart health, ask your cardiologist, because not everyone will really be able to give you a nuanced answer when it comes to supplements. And it's very important that you divulge exactly what you're taking.
Thank you. Yeah, very interesting. I know with all those supplements, the science starts to, like you said, like a pendulum, right? It goes back and forth and what's recommended, what's not recommended. So thank you. I think the next question is a more of an individual tailored question, and maybe this is more directed for Dr. Pelikan. So after getting a stent, how long should a person continue taking blood thinners?
It's variable depending on a number of issues. The easy answer is somewhere between 1 and 12 months. Specifically, most stents that are being used right now are called drug-eluting stents. They have a drug attached to them to prevent tissue from, tissue from growing inside the stent and clogging it up. That can sometimes slow down the body's own coating of the stent in the same way that Dr. Tang showed you that the body will cover the Watchman device. When you put a stent inside a coronary artery, it will get covered with some tissue that will prevent clotting. And the drug-coated stents maybe take longer to cover. So if you got a stent in the middle of a heart attack, you're going to be on the blood thinners for 12 months. If you got a non-drug coated stent, you could conceivably stop as early as 4 weeks after stent implantation. And even with drug-eluting stents or drug-coated stents, there are some research trials that have come out suggesting that between 1 and 3 months, you could stop the blood thinners.
Excellent, thank you. Okay, so I think we have 2 more questions. I know we're running out of time here, so we'll try to get through this quickly. The first question is treating a woman's heart different than treating a man's heart? Is there a noticeable difference in terms of what you see between men and women?
I'm happy to answer that. Briefly, the answer to that question is yes, there are differences. And in fact, the more that we learn as time goes on, the more that we find out that, hey, there are really some nuances here. Whereas in the past, we took this one size fits all or type of approach. We were learning that, especially when it comes to symptoms, these differ tremendously. And so another way of putting this is that women can have a lot of the classic symptoms that men do, especially when it comes to coronary disease and heart disease, but oftentimes they can present with something atypical. So something that doesn't sound sort of quite on par with what we sort of traditionally define as angina or heart related. And that can be the primary or only issue. And that's really where things get scary. So that's just sort of one aspect, of an answer to that question. And certainly, we're happy to discuss more if there are certain symptoms that, you're concerned about, or there's certain ways of sort of looking at things. But yes, and in fact, as the research comes out, even in terms of outcomes, looking at diagnosis, all of this is now being, gender stratified, so to say, because we're learning a lot more about the differences between the sexes.
Excellent. All right, last question for today is from Eric, who says, at what point do you put in a new valve or work on the mitral valve? I guess he has a mitral valve prolapse and his heart is getting large on one side to compensate. Is there anyone who might be able to weigh in on that?
I'm happy to weigh in on it. the easy answer is the devil is in the details. So how large is the enlarged chamber? That's issue number one. Issue number two is it enlarging? So if you have several echocardiograms over a period of time, you can tell if something is enlarged but stable in size and causing those symptoms. That would be a different situation than every 6 or 12 months. If you do an echocardiogram, that chamber is getting larger. In somebody with mitral prolapse who also has mitral regurgitation. So prolapse means the leaflets are sort of extra large and they're not meeting correctly, but that's by itself is okay. If you have mitral regurgitation, which is a back leak at the mitral valve, that will overload the heart because it's pumping extra blood. If you have severe or even moderately severe to severe regurgitation with symptoms, that's a no-brainer. Then you need a new mitral valve or preferably a repaired mitral valve. If you're completely asymptomatic, no symptoms, exercising well, and the chamber is a little bit enlarged, I would probably watch that, follow it, repeat the echo in 6 months. So it's a very complicated question that really knowing the details and following the patient is the way to figure that out.
Gotcha. Yes, and I know there are a few more questions, but for sake of time, I think we're out. What we'll do is we'll collect some of those questions that we didn't have a chance to answer today, and we'll try to consult with our expert team here and get you guys some answers. We'll try to email everybody as soon as we can. I would like to thank everybody for being here. Especially, I'd like to thank our team of experts for taking the time to provide us with this valuable information. Again, we will be sending a recording of the presentation to all attendees. So you have this. We will be posting it on our Facebook page for everyone to be able to view and share. You can find us at Prov St. John's on Facebook. And if you'd like to learn more about our physicians and cardiac services, please visit www.sjpp.org. That's sjpp.org or providence.org/St. John's. For any additional information or to schedule a physician appointment, please call 310-829-7678. We are also going to be sending out a Q&A, so we can try to gauge your feedback. It would be greatly appreciated if you could just take a few moments to answer the poll, which you'll see here. So we'll leave the room open just for a few seconds. This will better allow us to, structure future seminars in the most enjoyable and informative way in the future. Thanks again, and I appreciate everybody who was able to join today.
Thank you.
Thank you very much.
Thank you.